My name is Johanna Wong. I've attended ECC in Seattle for so many years, and so thank you for inviting me to, and Ada, to be part of a workshop here together about some depression and anxiety concerns in the community. So we are going to talk about some cases. What we were just working out was, I thought the whole talk would be translated, and so if anyone has any questions about some terms that I use, please raise your hands. We'll ask Faye to, we'll back up a little bit and we'll go through the terms. So we really definitely do want you to be comfortable with the terms that we use. There's not a lot of medical terms in the talk, but if you do need anything translated, just wave your hand, okay? Also, if you have any questions about what we're talking about, or you want me to slow down or back up or explain something else, please also just feel free to raise your hand, shout at me, and we will do that, all right? Okay, so we click. Oh. Okay. I told Patrick earlier that I am technologically not abled. Oh, yeah, there we go. All right. All right. So I appreciate you all coming together to learn about what can sometimes be a sensitive topic. We would like to help Ada and me make it much more familiar to you, and then hopefully with familiarity, we can have a better conversation in our own community. I have taught similar topics to medical students, not necessarily to a community group. So today we will try to spend some time learning about some mental health topics. It's a really broad topic. So we'll focus on particular areas, and we'd like to spend as much time as possible answering your questions. So you all may have a little index card, and we have more on the side table, and pens. If questions come up while we're talking, you can raise your hand and ask the question anytime. If you prefer, you can write down your question, and we will, at various points, collect these cards. You can just leave them back on the table at the side, or we'll collect them during our break, or various ways of getting the questions to us. And we will try to leave as much time towards the end to answer your questions. Okay, so feel comfortable, feel free. If questions come up, you know, it doesn't even have to do with the talk. If you have other questions or associated questions or things that come to mind, you have Ada, who's a wonderful counselor therapist here, and you've got us for an hour or two, so we're here to answer your questions. All right. Let's see. Okay, click. There we go. Today we will go through some cases that are pretty typical in my general internal medicine practice. This is the sort of work that I do frequently. We'll talk about some clinical information about the disorders. This is what I call the medical student part of the talk. And then we'll talk about some common scenarios that occur in the workplace, in the school setting, in the community, in the church. And again, try to leave a lot of time for your questions. All right. So we're going to zip through some of this, and we'll have time here in a couple of minutes to look at this a little more closely, but I'll just read this off to you. Case number 1, 20-year-old young man who's a political science student from China arrived in the United States 6 months ago. He presents to the doctor's office with friends who feel he's been acting bizarre the last couple months. He says he feels well, he misses home, he misses family. He's not eating well. He's lost about 5 pounds of weight. He doesn't sleep much at night, maybe 3 to 4 hours. He spends nighttime hours watching movies, playing video games, and he spends time online in blogs talking about politics. He has an interest in conspiracy theory in politics. He is no longer going to class or completing assignments. Friends note they are concerned about experimentation with alcohol and drugs. On exam, he weighs 110 pounds. He appears calm. He's a little disheveled. He's a little not neat. He has poor eye contact. He speaks softly. He describes his classes in political science and has quite a few theories about how the Chinese government is watching his studies and monitoring his movement in the United States. As a result, he often disconnects his phone and computer. He declines to Skype with family at home due to concerns about surveillance. Okay, technical. There we go. Okay, which statement is most correct? He is exhibiting normal 20-year-old student behavior. B, he is showing situation-appropriate anxiety. C, his sleep patterns indicate he has a general anxiety disorder. And D, he has a mood disorder with psychotic features. All right, we will come back to some of this stuff. Case number 2. 82-year-old Chinese woman with significant past medical history for hypertension and a recent stroke causing some mild speech changes, and she comes with family for a blood pressure check. She eats well, sleeps more since the stroke. She has reduced focus, concentration, and poor memory since the stroke. She's less interested in family activities. She's a little self-conscious about her speech, makes it a little hard to socialize, and since her stroke, her family says she's very concerned with planning her funeral. Her exam, she's well-dressed, she's an elderly woman, she looks younger than her 82 years, slightly high blood pressure, good eye contact, she does not look anxious, she has a small amount of word-finding difficulty. She scores 24 out of 30 points on a mini mental status exam. That's something we do at work, which tests various areas of memory and orientation. She has a little bit of trouble identifying the date, and she has reduced memory, and her neurologic exam is otherwise normal. And which statement is correct here? This patient exhibits expected consequences after a mild stroke at age 82, and she's recovering well. B, her reduced memory is mildly concerning, but it's related to her stroke. C, she has major depression. D, she has onset of dementia after the stroke. Okay. Case number 3. 42-year-old woman comes alone to the office. She states she's not feeling herself. She could stay in bed all day if allowed. She no longer enjoys family activities, gardening, nothing sounds fun. She cries. She's very exhausted, no energy. She wakes up at 3 a.m. every night and cannot get back to sleep. She has no sex drive. She has more arguments with her family. They describe her as jumpy and irritable. And when questioned, she thinks frequently, daily, about what her family's life would be like if she disappeared. She's well-dressed, she's a little tearful, she speaks normally. Her weight shows that she's about 10 pounds heavier in the last 1 year. Which statement most points to major depression? A, she could stay in bed. B, she lacks enjoyment. C, she thinks about death and dying. D, she has early morning awakening. E, she's exhausted. F, she's irritable. Or G, all of the above. Always go for all of the above. Case number 4. 24-year-old woman delivered her first child 3 months ago. She comes to the office reporting she feels tired all the time. She's breastfeeding without problems. She cries easily, daily. Her sleep is disrupted because she's feeding the baby at night. She feels she is not bonding. She feels she is bonding with her child, but not enjoying or remembering much of the first 3 months. Her past medical history, she did have anxiety during her teenage years, and she has a history for benign thyroid nodules. Her family history, her mom and one sister have a history for anxiety and depression. Her mom has thyroid disease. In social history, she's staying home with the child. Her spouse works. They do not have family in town. There is no history for domestic violence or abuse in the household. She appears well. The infant is present with her in the office, and she looks to be well bonded with the child. Okay. and several statements, which is the most correct. A, she shows postpartum depression and should take medication immediately. B, she has mild adjustment disorder since the delivery of her infant. No medication needed. C, she experiences what many new moms experience, and just reassure her. D, she's experiencing disconnect syndrome and needs a community group. Or E, she has thyroid disease. All right. Major depression occurs in many age groups, most commonly in people under age 65. In the United States, women have an estimated 30 to 40% chance for developing at least one event of depression in her lifetime. So over the course of her life, 30 up to 40% chance of having depression. Men have an estimated 20 to 30% chance. This year, 4 to 10% of the entire United States population will develop depression. This is very, very common condition. Worldwide, depression is actually increasing. In the United States and Europe, 20 to 30% of us will have depression. Estimates for developing countries, China and Brazil, for example, are 10 to 15% lifetime prevalence. Lots of primary care medical office visits originate in depression. You know, people will come to their general medicine doctor. They'll come for backaches, headaches, stomach aches, etc. But the fundamental underlying concern could be depression and anxiety. Lots of work days are lost, lots of financial burden due to this concern. Depression is basically as common as diabetes. 10% of us in the US population have diabetes, and as common as high blood pressure. About 30% of all of us have high blood pressure in America. And so depression is just as common as these very ordinary conditions we think about, you know, diabetes and high blood pressure. So if you think about it, just in this group here in this room, about 10% of us have diabetes, about 30% of us have high blood pressure, about 10% of us have depression, and a few of us are dealing with all three, all at the same time. Okay. Family history is important. Recurrence is common. If untreated, up to 50% recurrence will occur within 1 year, and about 62% recurrence at 2 years. So while depression will sometimes fade away and kind of fix itself, it does come back very frequently at rates that are somewhere in the 50 to 60% range as early as 2 years down the line. Sometimes people are showing psychosis features. Psychosis means that people can hear voices, they can have visual hallucinations, and they can have paranoid thinking. And there's a lot of overlap with anxiety conditions. Those conditions often occur together. Pregnancy and postpartum depression. Postpartum depression is a very special type, but very common. Most women will show their first episode of depression between the ages of 20 and 40. Women who have had prior depression are very extremely likely to develop postpartum depression, as much as an 80% chance of developing depression after delivering their child. And interestingly, even in the medical field, when pregnant women are asked if they are depressed, and they say, yes, I am depressed, still 80% of them and up go untreated for depression. So it's a really undertreated, under-recognized condition. Okay, so in the office, we use a couple of screening questions. We can identify depression, or try to, by asking a couple of effective questions. The first is, over the past 2 weeks, have you felt down? Have you felt depressed? Have you felt hopeless? And the second is, over the past 2 weeks, have you felt reduced interest or pleasure in doing things? And if a person answers yes to one or both of these questions, it's an effective way to screen for depression. In my office, we actually ask these questions of everybody. It seems like a lot of work, but we do it. So even if they come in for a cold, even if they're coming in for a back problem, we ask these questions. All right. If they say yes to one of those two questions in my office, they get a lengthy, moderately lengthy questionnaire. This questionnaire actually is in this little handout that we have for you. And basically the point is not to get too caught up in it, but just to say that we can ask some relevant questions, and it can help classify folks as having mild, moderate, or severe depression in the office. And it identifies functional changes in how people are doing in their day-to-day life. So if you have interest in this, there is a little handout and you can look at it further later on. Okay. With even more detail, and again, this is in the handout, there are actual formal criteria for diagnosing depression. So basically, we don't diagnose depression by sort of talking to people and sort of getting a feeling, like, oh, I feel like Bob has depression. There actually are formal criteria, and they're basically fundamentally boiled down to, number one, people have a feeling of sadness and worthlessness for a persistently long period of time, and basically people have reduced interest in their day-to-day activities. From our cases, what we'll explore is that people can describe their life in many, many different ways, but if you boil it all the way down, even on formal criteria, you can determine that people actually do have the same depression or anxiety condition. I highlight that less than 5 of the criteria, and you can't even read that at all, sorry. Okay, but there are these criteria. It's in your handout if you want to look at it. Less than 5 does not constitute depression. And when many people come to the office, they're coming for a 15 or 20-minute visit. You know, that's really a short visit, and it's not enough time to ask careful questions. But I think given enough time and attention, it's not difficult to find 5 of these criteria on a basic office visit. Okay, so we are going to come back to these cases, and I think what we'll do is, Lunching's got a bunch of stuff for us. Okay. So if you all can, what we'd like you to do is group yourselves into groups of like 3 or 4 people, 2 people, and we're going to go through these cases. And just take a moment, based on some of the things we had talked about, and circle things that you might find relevant about the cases. It just gives you an opportunity to look through these with a little more time. So we'll take about 5 or 8 minutes to do this.